Hi, my name is Zachariah Malik, and today I'm going to be talking about a spontaneous pneumothorax in a patient with COVID-19 managed with a chest tube. To start off with an introduction, a spontaneous pneumothorax is defined as the presence of air in the pleural space without an obvious precipitating event. In the general population, a primary spontaneous pneumothorax has an incidence of 7.4 to 18 cases per 100,000 males. It typically occurs in tall, thin males with cigarette smoking being an additional risk factor. Barotrauma was reported in 15%, 89 out of 601 COVID-19 patients who required mechanical ventilation. Additionally, patients without COVID-19 with invasive mechanical ventilation had one barotrauma event out of 196 patients. However, spontaneous pneumothorax in COVID-19 patients who are not mechanically ventilated has not been frequently reported and is estimated to be around 1%. We report a case of spontaneous pneumothorax requiring chest tube placement in a COVID-19 patient who was not on mechanical ventilation. Here's a case description. A 68-year-old, 6-foot tall, Caucasian male with obesity, a BMI of 30, hypertension, hyperlipidemia, former cigarette smoker of 12 and a half pack years, was admitted for acute hypoxemic respiratory failure secondary to COVID-19 pneumonia. Initial management included oxygen therapy through high-flow nasal cannula, 5 days of IV remdesivir, and 2 days of IV methylprednisolone. The patient's D-dimer uptrended from 227 to 662. He became progressively hypoxic despite on high flows in nasal cannula. Therefore, a chest CT angiogram was ordered, which was remarkable for a 3.1 centimeter right-sided pneumothorax. A chest tube was placed with subsequent X-ray showing improvement in the pneumothorax. His condition slowly improved, and his chest tube was subsequently removed. The patient was later discharged home on supplemental oxygen. Here are some images from the case. A CT angio chest axial view revealed a spontaneous pneumothorax of at least 20% volume of the right hemothorax, and it measured 3.1 centimeters from the anterior right chest wall. The lungs showed diffuse moderate to severe ground glass airspace disease and areas of patchy consolidation consistent with COVID-19. The X-ray of the chest is post right chest tube placement with a tip at the apex, and no pneumothorax was seen. Further discussion includes a spontaneous pneumothorax in COVID-19 patients not on mechanical ventilation has not been frequently reported, and only a few patients were found on our literature review. These cases were primarily treated with chest tube placement. We believe that COVID-19 infection might have contributed to the development of spontaneous pneumothorax in our patient. Spontaneous pneumothorax should be considered as a differential diagnosis in a patient with COVID-19 with increasing oxygen requirements. References are listed as well. Thank you.